Hi friends, in today's class we will discuss about Stevens-Johnson syndrome and its ocular complications. So the disease spectrum, pathophysiology, complications management, Gregory grading and the sequelae of SJS. So coming to what is SJS, it is an ocular surface disorder. It is also called as erythema multiforme major. So in this we have ocular surface failure. So in type 1 failure of ocular surface, there is squamous metaplasia. So in squamous metaplasia, non-keratinized epithelium becomes keratinized, and there is goblet cell insufficiency. And in type 2, there is limbal stem cell deficiency, because of which corneal epithelium becomes conjunctival epithelium. So this is a ocular surface failure disorder. So the disease spectrum is it is more common in females 10 to 30 years of age, and it is a acute self-limiting disorder. Vesicular-bullous disorder affecting the skin and at least 2 mucous membranes. So it is primarily a dermatological disorder. So based on the disease spectrum, it can be divided into Stevens-Johnson syndrome, SJS. So if it is involving less than 10% of the body surface area, and there is SJS TEN overlap, that is 10 to 30% of the body surface area, and if it is above 30%, it is called toxic epidermal necrolysis, that is 10. And the mortality rate is almost 1 to 5% in SJS, while it is almost 25 to 40% in case of TEN. So the predisposing factor is idiosyncratic reaction to drugs, and that is most commonly sulfonamides. In the pathophysiology, there is type 4 delayed hypersensitivity reaction by CD8 cells, which causes TNF-alpha activation, leading to keratinocyte apoptosis and epidermal necrosis. There are some HLA related ones also. We have associations like HLA B1502 for carbamazepine, HLA DR7 for sulfonamides, HLA B12 for NSAIDs. So these genetic predispositions also are the factors which can lead to the formation. So coming to how it affects the ocular surface. So they can be in acute stages, they can be acute conjunctival hyperemia, which can lead to in later stages pseudomembrane formation, in severe cases they can be ocular surface sloughing, and also lid margin de-epithelialization. So this acute can lead to sequelae like, so this pseudomembrane formation can lead to symblepharon formation later. This ocular surface swelling can cause corneal ulcers or perforation. This lid margin de-epithelialization can cause fornix, foreshortening. Okay, so these are the acute ones. Coming to some chronic ones, there is lid margin keratinization. So this leads to meibomian gland atrophy, which in turn lead to dry eye disease, and this can also lead to punctal occlusion. So these are all interrelated things, right? And also altered brain. So this can also lead to a dry eye disease. So these are all interrelated things, right? So coming to its sequelae or side effects, so this lid margin keratinization also can cause symblepharon and chyloblepharon. Ectropion, entropion, trichiasis, dystrichiasis. All this can be caused by it, right? And so the symblepharon in turn can also lead to ocular motility restriction, lag of ophthalmos, and chronic exposure. So all these are the acute and chronic ocular manifestations and their side effects or sequelae. All this can finally lead to end stage corneal blindness. Okay, now So an acute one is actually a medical emergency which is managed with high dose pulse steroid, human IVIG, that is immunoglobulins, immunomodulation, and plasmapheresis. So the ocular involvement is based on Gregory et al. Grading system, which is for acute SJS, for ocular involvement. So this is for acute SJS. Ocular involvement is Gregory grading system. Okay, so let us understand what is it. So it is divided into mild, moderate, severe, and very severe. So based on involvement of lid margin, cornea, conjunctiva, that is both palpebral and bulbar, and the treatment part. Okay, so it's mainly based on the lid margin, cornea, and conjunctival involvement. So this is an ocular surface disorder, right? So these three are included in this. So we perform a staining in these cases with fluorescent strip. So if it is not taking any stain, so on FS staining, so if the stain is negative and there is less than 1/3 of the lid margin is involved, in mild cases the stain is negative in lid margin, cornea, as well as the conjunctiva, and treatment is just medical management. In moderate cases, stain is taken up less than 1/3 of the lid margin, cornea is not involved, and conjunctiva is less than 1 centimeter involvement. So there is treatment is by medical management along with observation. In severe cases, it is involving more than 1/3 of lid margin, cornea is taking up stain, more than 1 centimeter of conjunctiva is taking up stain. Here it requires medical management along with urgent amniotic membrane transplantation. So in very severe cases, there is more than 1/3 involvement of both the lids, both eyelids. Cornea is taking up stain, conjunctiva is more than 1 centimeter, and along with multiple areas are involved. So it requires medical management, urgent AMT, and repeat amniotic membrane transplant if required. So this was the acute SJS management by Gregory grading system. Okay. So coming to the chronic SJS sequelae, as we have all discussed over here. So these are all the sequelae in the right side which we have all seen, right? So what we'll do, So how do we treat these all things? So there is symblepharon, lag of thalmus, entropion, ectropion, dry eye disease, and keratinization and end-stage blindness, right? So all these need to be managed. So the management of all these is itself a very different class. So we have to discuss about the procedures which are done from ectropion and entropion, like lateral canthoplasty, laminar repositioning, all those, and management of dry eye disease with the help of artificial tears, punctal cautery, salivary gland transplantation. So all those we have to mention. So if it is asked as a question, we should also mention the treatment part of all these things. So in case of end stage corneal blindness, we need to go for mucous membrane grafting and keratoprosthesis. So mucous membrane graft can be taken from oral mucosa, and keratoprosthesis, we have Boston type 1, modified type 1, and type 2 also. So type 1 is for wet surface, whereas type 2 is for dry surface. We have osteodonto keratoprosthesis. So these are all separate things. Then we have one thing that is PROSE, that is the scleral contact lens. So what is PROSE? It is prosthetic replacement of ocular surface ecosystem. So in this there is less pain, improvement of vision in some cases, and it improves healing in case of corneal involvement, and it reduces the trauma which is caused by the keratinization of lid margins, right? So this contact lens can also be tried. So this was regarding Steven-Johnson syndrome, the pathogenesis, disease spectrum, acute and chronic sequelae, management by Gregory grading system, and the treatment part which is described by it, Gregory. So thank you for watching the video. I hope you liked this video. So please subscribe to my channel and hit the bell icon. Thank you.